Good afternoon, everyone. My name is Racine Lawrence, and I am a communication and marketing specialist with the Centers for Disease Control and Prevention. I identify as female, I have on a white shirt, and I prefer the pronouns she and her. I would like to welcome you to today's CDC Emergency Partners Information Connection or EPIC webinar. If this is your first webinar with us, welcome. We invite you to learn more about CDC's emergency response communications activities, including past webinars and newsletters, at our EPIC webpage at emergency.cdc.gov. Today's webinar will be recorded and posted to our website in the coming days. If you do not wish for your participation to be recorded, please exit at this time. Closed captioning is available for this webinar, and to view those closed captions, please click the More option, the three dots, and select Show Subtitle. Be aware that this option may differ depending on your device. We are also offering ASL interpretation, which will be pinned to your screen to view throughout the webinar. Right, next slide. We are pleased to offer continuing education credits for this webinar. Additional information will be shared at the conclusion of the webinar, including how you may take advantage of this opportunity. Please take a moment to review the disclosure statement displayed on your screen. Okay, next slide. To achieve health equity, we need all sectors to expand access and remove the social and economic obstacles that lead to poor health outcomes. One of these social obstacles is health communications, specifically communication that does not adapt to the specific cultural, linguistic, environmental, and historical situations of populations or audiences of focus. Today's EPIC webinar is all about giving you the background and resources you need to create communications that do just that, including CDC's Health Equity Guiding Principles for Inclusive Communication. Throughout the webinar, we will drop links in the chat box for information that we hope you will find useful. The chat feature will be disabled for participants during the webinar. If you would like to ask a question, please submit using the Q&A feature. We will do our best to answer as many questions as possible. Next slide. It is a great pleasure for me to introduce today's speakers. We will be hearing from Dr. Desmond Banks, who will walk us through the basics of health disparities as well as CDC's commitment to transforming systems and policies to increase health equity. Dr. Banks holds a PhD from the Johns Hopkins Bloomberg School of Public Health and a master's in public health from Hunter College at the City University of New York. He serves as an epidemiologist within the Office of Minority Health and Health Equity Science team at CDC. We're also joined by Dr. Susan Laird, and she will be discussing why inclusive language and concepts are so essential to good health communications and will introduce CDC's Health Equity Guiding Principles for Inclusive Communications. Dr. Laird holds a doctorate in nursing practice and a Master of Science in Nursing, both from Georgia State University. She is a training and education lead in the Division of Communication Science and Services in the Office of the Associate Director for Communications at CDC. Okay, so we have a lot of important information to get through, so we're going to go ahead and get started. As a reminder, if you'd like to ask a question, please utilize the Q&A button, and we'll get to them directly following the presentation. Okay, Dr. Banks, over to you.
Thank you very, very much, Racine, and thank you all for joining us here today. As you can imagine, much of our communication with you over the past 2 years plus has been somber, as we've been engrossed with the COVID-19 pandemic, but today is a joyous day. right? Today, we get to talk about some of the great things that we're doing to help use the lessons learned from the pandemic to help advance the health of all populations and to promote health equity. Next slide. So if we may, let's please introduce some level setting. Let's start today with a few terms. Many of these may be familiar with you. We're going to discuss three key terms. First, social determinants of health, all right, SDOH. Social determinants of health, which are identified as conditions in which people are born, grow, live, work, and age. Social determinants of health are shaped by the distribution of money, power, and resources throughout local communities, nations, and the world. All right. Second, we have health disparities, which are preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by populations that have been disadvantaged by their social or economic status, their geographic location, and their environment. Third, and finally, we have health equity, which is the state in which everyone has a fair and just opportunity to attain their highest levels of health. Okay. It may be helpful for you to think of these terms along a continuum where differences in SDOH, or social determinants of health, lead to health disparities, while health equity seeks to reverse the differences in health or reduce these disparities towards a more stable social determinant of health for everyone, and to promote health equity. Next slide. Health equity is extremely important. As we're all aware, the population health impact of COVID-19 has exposed long-standing inequities that have systematically undermined the physical, social, economic, and emotional health of racial and ethnic minority populations and other population groups that are bearing a disproportionate burden of COVID-19. Across the country, people in some racial and ethnic minority groups experience higher rates of poor health and disease for a wide range of health conditions. You see many of them on the screen here, including diabetes, hypertension, obesity, asthma, heart disease, cancer, preterm birth, compared to their white counterparts. CDC health equity efforts look to close these gaps by working to reduce and ultimately eliminate racial and ethnic minority health inequities by addressing structural and social condition. Importantly, racism, looking specifically as racism as a fundamental driver of these inequities. Next slide. So what are we doing? What is CDC doing to achieve health equity? To achieve health equity, we must change the systems and policies that have resulted in the generational injustices that give rise to racial and ethnic health disparities. Through our core strategy, we're leading this effort. But in the work we do on behalf of the nation's health and the work we do internally as an organization, in both of them, including the language that we use and encourage others to use. We have a core strategy. We're going to read through them here. Cultivating comprehensive health equity science involves the standardization of health equity language and principles. That's the C. O, optimizing interventions requires the use of respectful and inclusive language in our communications. Respectful and inclusive language. R, reinforcing and expanding robust partnerships requires that we engage with public health stakeholders to communicate health equity science and principles. And finally, E, enhancing capacity and workforce engagement is one of the primary objectives of our core strategy, and is one of the key reasons why we're meeting with you today. I can't tell you how committed and excited we are about this work. As part of our work on the core strategy, we're looking at specifically at something that you may or may not be familiar with, but hopefully will become more familiar with as time goes on. The concept of gendered racism, okay, which is the intersections of gender and race, how gender and race, those combinations, result in experiences that are amplified, experiences of racism that are separate from racism by sex alone. We're looking at gendered racism within the workplace. We're looking at all these things. And I kind of bring this home. You may be familiar with the fact that for Black women, even with the college degree, okay, Black women, even with the college degree, you're still 5 times more likely to die due to pregnancy-related complications compared to your white counterparts. We're looking at that, okay? We're looking at the intersection of gender race among Black men, how Black men are 30 times more likely to be incarcerated than have high levels of employment, specifically senior levels of employment. These are difficult concepts to digest. These are difficult conversations to have, difficult data to even look at, but we're doing it. It's important that we're doing it. We're committed. We work around the clock. We're committed to it. We are talking about the most important and pressing and difficult to discuss health issues of our time, because we understand that we have to be authentic and we have to look at these things internally if we expect you to do it. And we're just so excited to have you with today. As you can tell, the excitement here in my voice. Next, we're going to hear some great language today. And so I'll turn it back over to you, Racine.
Thank you, Dr. Banks. Thank you so much for sharing your thoughts on how we all can contribute to reducing health disparities within our communities. Next, we'll be hearing from Dr. Susan Laird. Thank you so much. Dr. Laird, if you're ready, we're ready to hear from you today.
I am ready. I started my video, but I'm not seeing it. There I am. So thank you. First, I really want to thank everybody for being here today. We want to share our passion and our commitment to this work in a way that's going to hopefully entice you to join the work too. I'm going to cover a lot of ground in a short period of time. And our ultimate goal is to enlighten as many people as possible. So to just consider looking at the world through a health equity lens. Next slide. Next slide, please. So Atul Gawande is a personal favorite of mine, and I appreciate and agree with his take on changes and improvements in healthcare delivery. In his first book shown here, he states it clearly that if we just don't know, then we do the best we can. But when we do know and we don't do the right things, then there's much work to do. The work in health equity and inclusive communication is designed to put us all in the know. Next slide. Now, COVID forced us, if you will, to take a very hard look at the long-standing inequities that made them worse. From the beginning of the COVID response, we were able to quickly see that race was a factor in disparities and even deaths from COVID-19. Next slide. So what is the why part here? And while COVID did shine an additional light on the issues of race and social determinants of health, it's not just COVID. We've known, pretty much as Dr. Banks said, we've known for years that there are much higher numbers of maternal mortality in Black women. And these issues are often reflecting the historical impact of the social determinants of health. Next slide. And you likely saw this just a week before last. It was the latest issue of Vital Signs for MMWR. And it was yet another example of the impact of the social determinants of health. Next slide. So why are we putting so much energy into this, and why now? Next slide. We know that social determinants of health have proven to us that stigmatizing language can actually hurt people by influencing other people's judgment of those populations. So stigma is defined as an attribute, a behavior, or condition that's socially discredited. And stigma is influenced by two main factors, cause and controllability. So in terms of cause, when people believe that an individual is not responsible for the attribute of the behavior or the condition, meaning it's not their fault or they can't help it, then stigma is diminished. Research has shown that our use of stigmatizing terms may influence judgments, basically that a person's either bad or good, worthy or not, as well as the need for punishment versus treatment. So it's important to remember that we personally can't determine the level of pain that stigma causes someone else. Next slide. I think this is a great example. The person on the left, when referred to as a substance abuser, versus the person on the right that has a substance use disorder. The person that was referred to as an abuser is a lot less likely to benefit from treatment, and that the problem was the result of some innate dysfunction over which they had no control. More likely, they would benefit from punishment, be a socially threatening person and be blamed for their substance-related difficulties, where the substance on the right was more deserving of treatment. Next slide.
Oh, Susan, I'm sorry to interrupt you. Could you adjust your microphone a little bit? We're having a little trouble hearing you clearly.
Let me try holding it closer.
That is awesome.
Is
Yes.
that helping? Okay.
Yes, ma'am.
Thank you. So for the next slide, to continue the discussion about stigma, probably one of the most profound examples of stigma has been directed towards people living with HIV and AIDS. And from the time the virus was discovered, this stigma continues to this day, and it impacts not only those with the virus, but also the LGBTQ community. Next slide. Now, health equity and health literacy and accessibility go hand in hand. Using health literacy principles is one step in addressing health inequity. For example, use plain language, test the materials with your intended audiences, provide translation services for people with limited English proficiency, and design your websites so they're accessible to people who use assistive technology. Next slide. So let's get a little bit deeper into what it means to use a health equity lens. Next slide. Now, the key word here for me is intentional. Look at your messaging and materials and identify the potential positives and negatives that may impact your audiences. You want to be more effective, right? So get input from your intended audiences. Ask them how they want to be identified. How can we be useful to you? That's what we did with the development of the guiding principles. We asked working groups at CDC to start with. Next slide. So there are a few questions you need to ask if you're going to apply a health equity lens. How are social and health inequities at play? Next slide. Now, most of us in our respective work environments are aware of all these contributing factors. And some of these may even seem redundant since they all lead back to the same problem. But I want to point out the significance of our own assumptions and biases. These evolve from the way we were raised, our experiences, our exposures to different cultures, and they all play a major role in how we perceive others, both positively and negatively. Next slide. A health equity lens helps us see beyond our own worldviews by engaging our communities and populations of focus in the decision-making process. So people and groups appreciate being asked about their worldviews. And when we ask, we usually learn something. Next slide. So finally, if you do this activity, this action that you're planning, will you unintentionally cause problems? Are you overlooking risks and benefits? And is your message saying what you want and need to say? And are you staying within the appropriate context? Next slide. So I want to share this with you because I think it's kind of a good indicator of where we are in this work and what more needs to be done. So I was looking for a graphic that would demonstrate what intersectionality means. So I started with cdc.gov. I mean, why wouldn't I? And this is what came up first. From the Injury Center, a call to enforce red lights. Clearly, we need to look a little deeper. Next slide. So one clear definition of intersectionality is that people often, and usually, belong to more than one group. I'm a woman, a wife, mother, grandmother, I'm a nurse, I'm a health communications specialist, and I have multiple interests and life experiences. So people may belong to more than one group that has historically and currently faced discrimination. So we should consider this in our analyses and communications. One example, a Black woman may experience discrimination based on her race or her gender. She might identify with experiences of white women as well as with the experiences of Black men, but her experiences as a Black woman may differ from either of the other groups. Next slide. So one of our basic tenets is engaging with your audience. Next slide. Now, our sister agency, the Agency for Toxic Substances and the Disease Registry, probably a great place to start. They literally wrote the book on the principles of community engagement. I encourage you to go to the website and check it out. They have 9 principles for community engagement. Next slide. You want to be clear about your purposes, partner with the community to create necessary change and improve health. And all aspects of community engagement must recognize and respect the diversity of the community itself. Awareness of the various cultures of the community and other factors affecting diversity must be paramount in planning, designing, and implementing approaches to changing a community. And community engagement can only be sustained by identifying and mobilizing that community's assets and strengths, by developing the community's capacity and resources to make decisions and take action. Next slide. Now, there are a lot of people that think that generations no longer make a difference. I think if we believe that, we're leaving out a very significant contributing factor, and we can't understand without taking that into consideration. We currently work in a 4-generation environment, and understanding the different points of view will help us frame the conversation and the messaging to make change. In Lynn Lancaster and David Stillman's book, which is old now, but it's called When Generations Collide, they identified drivers of perspectives based on when people were born. For example, people from the Depression era may have experienced hunger. My own mother hoarded food her entire life, long after she could easily fill her cabinets. There is a new book out that I'm still reading right now. It's called Stage Not Age. The author's called by the name of Susan Golden. And she refers to the fastest growing population in our country as 65 plus. And we're still working. So it's going to be important that we consider not just X, Y, and Z, but those of us that are still in the workplace and in the marketplace and need to have messaging tailored to our needs. Next slide. Now, last year, People magazine ran a feature story on Gabrielle Union, and they asked her directly about the issues of racism in Hollywood. And so what we used to find funny isn't funny anymore. This one particular example of blackface in musicals, they were very popular in the 1930s and 40s. And children of parents who grew up in those households may not know that blackface is inappropriate. Just within the last couple of years, there have been multiple examples of, including well-known political types, showing up at parties in blackface. It's just not funny. If it ever really was, it certainly isn't now. So could you think of other examples where we once laughed at jokes that are no longer funny? I think if you really thought about it, you probably could. Next slide. So I want to talk about the purpose of the guiding principles, and we're hoping to just start the discussion. We hope that you start thinking about this work so we can collectively reach our goals. Next slide. So in the process and after the launch of the guiding principles, we received both feedback and pushback. I guess the difference in those two are that the feedback was constructive and we made changes to reflect really good ideas. The pushback, not so much. Pushback came to our email box, and some of it was really harsh, even mean, and even a few people used our suggested words to basically attack us. Next slide. I don't know how many of you saw the Super Bowl in February, but Billie Jean King was there to do the coin toss, and she was a recent recipient of the Presidential Medal of Honor. she was marking the 50th anniversary of sports gender equality legislation, Title IX. So in her acceptance, she noted that it's hard to understand inclusion unless you've experienced exclusion. And I think that's a really good place to start, with an understanding that this work is hard and not everyone will be supportive and not everyone will be understanding. Next slide. So I want to talk about what health equity guiding principles is and what it is not. So first, it's really important that we focus on the foundational concepts, not the preferred terms. The terms themselves are just examples. And as we continue to say, they're not prescriptive, and they're certainly not our only options. You may come up with many that are far more inclusive than what we chose in the guiding principles. And it's important to note there are no mandates here. You don't have to use these exact terms. We just think you should give them a chance. We learned at CDC that there were some supervisors that were saying, you must use these. But I want to repeat, they're not a CDC mandate by any means. And again, you may find much better terms that apply to your population of focus. So the health equity guiding principles emphasizes the importance of addressing all people inclusively and with respect. Next slide, please. Now, here are the terms to avoid, and these are kind of the underlying foundational principles. Reframing messaging to be aware that what we say about others has an impact, and we want those messages to connect with our audiences. We've referred to target audiences and vulnerable populations for so long, it's a habit. And habit takes change. Habit takes effort and energy, and it isn't going to take overnight. Next slide, please. Again, I want to really stress that these are recommended terms to just start your thinking about what might work. We're finding one great example, we hear this a lot when we make presentations. People ask about the phrase pregnant people. Comes up in a lot of the pushback we receive. The intent initially was to come up with words that were inclusive towards transgender audiences, perhaps. But the risk of offending pregnant women is currently very high. So we weigh the potential impact against our intended audiences, and then we make a decision based on who's going to benefit the most from our messaging. Maybe we just say people who are pregnant and let it go at that. Next slide. So this is an old quote from business guru Peter Drucker, but it deserves revisiting. Culture will rule every time. It's important that we become culturally literate as well. So when possible, translate materials into the preferred language of your audience. And as we've said before, engage the community at the beginning, not as an afterthought. Next slide. Now, as a person that doesn't relate well to being called the elderly, I have a couple pet peeves I want to share with you. As we age, we're indeed at increased risk, but there are miles and miles between me and the nursing home, at least I hope so. And if you want to reach these audiences, think of different ways to categorize people. We're not all sick. As I said, I have a pet peeve. I'm an ER nurse by discipline. And when healthcare providers come into a room in ER and they see an older person, maybe with gray hair and a few wrinkles, and they immediately start yelling, raising their voices in the assumption that the patient's hard of hearing just because they're older. So beware that age and associated risk are often on a continuum, and risk for many diseases and more severe outcomes increase with age. Tailor these guidance to specific settings when appropriate, such as long-term care facilities. And signs and symptoms of many diseases may be atypical, delayed, or attenuated in older adults. That caregivers themselves are also older adults, and they may have additional risks. So use audience-preferred channels and platforms. And remember that not all of us are hard of hearing. Next slide, please. So it's important that we address choosing the right images when we're designing our communications. Next slide. Now, this is from a Google search I did for white doctors, white coats rather. As you can see, there are very minimal diversity. They're mostly male and white, and that was all we got in that search. Next slide. So we're working hard on new resources that will help us all choose better examples of diverse populations, depicting everyone in a very positive light. A picture is worth 1,000 words, and we want to be sure that we're paying as much attention to the images that we're using as we do to the words that we use. Next slide, please. Giving the graphics the same attention as we do the language can seem a little more difficult. So we're developing some products you'll be able to use. We hope to have them available on our Health Equity Guiding Principles website in the next couple of weeks. But these are the basic considerations that you should use. Next slide. Now, this is an example of how we would suggest you could evaluate your images. You take the basics across the top and then put the graphic or photograph that you're selecting and ask these questions. You may not get all yeses, and that's okay. But the more yeses you get, the better selection you've made. So as I said, look for that in a couple of weeks on our Health Equity Guiding website. Just some ways to help you go through that process. Next slide. We want to share and summarize a few tips and takeaways here, especially to help you implement this work in your own organization, your own CIO. Allow opportunities for people to make adjustments. What does this really mean? Well, go back to one of our original statements. Not everybody comes from the same place. You know, for example, CDC is a really big place. And just because we all work in public health, it doesn't mean that we all think the same way or live the same way. So we start by being a little kinder right here within our own organization. We would ask you to do the same thing. Allow opportunities for people to make adjustments. What does this mean? It means that nothing is set in stone, and practice is going to make perfect, and practice will also make permanent. So what is your personal contribution to this effort? What matters to you? Next slide. I think we just skipped a slide. Yeah. So in order to make it stick, you've got to start. Start using the Health Equity Guiding Principles. Refer to them before and during the development of your communications. Look at the materials through that health equity lens, and look within your organization, and certainly look within yourself before you look outside. Next slide. Remember that this is not a finished process. I don't know that we're ever going to be finished. This work is going to change as culture and language changes. And it's important to understand when culture changes. Listen to learn when the language changes. Incorporate communities into the learning process, our learning process. Build relationships with communities to obtain their input and invite them to be part of the solution. Next slide. Maybe start by taking a look at your website through the health equity lens. That's a really good starting point. Look at places where the work needs to be considered. And some of your web pages may need a serious overhaul. Inaction only perpetuates the problem. So taking a general approach will not correct those inequities, but being intentional and specific will give you a good start. Challenge the status quo. Next slide. So one of our biggest challenges is determining how we're going to measure success. How are we going to know that we helped make a difference? It can take generations to make behavior change. Change takes time. There are policies and procedures here at CDC that other organizations can leverage too. So how serious are these organizations about health equity, and what policies can we begin to change? In the area of communication, we can do quantitative quantitative assessment of materials that are compliant, but we can do a number of trainings. But how people think and how they interact is harder to measure. So perhaps plain language and clear communication and an improved understanding of accessibility will help. Next slide. Consistency will be a major part of making it stick. Strive to have an open mind, personally and collectively. Be willing to listen and adapt to the changing climate. And again, use that health equity lens across all of your work. Next slide. Know up front that not everybody's going to get it. As I said, CDC is a big place. I'm sure your organizations are as well. Just because we all work here doesn't mean we think the same thing the same way. We don't talk the same way. We don't act the same way. And maybe you're struggling too. So invite others to the table. Continuously engage colleagues to discuss content and implementation. Increase understanding to obtain buy-in. And remember that forgiveness and encouragement are far more effective than blaming and shaming. Ask for help and share your own ideas for improvement. Next slide. So this takes us first full circle from Atul Gawande back to Maya Angelou. The message and the call to action is the same. We can do better. Next slide. And this is my final slide that I think requires you to just take a moment, think about it, absorb what it says. Diversity is a fact, equity is a choice, inclusion is an action, and belonging is an outcome. And with that, thank you so much for your attention. And I hope we have some great questions. Back to you, Rashid.
Thank you so much, Dr. Laird, for sharing these inclusive approaches that can inform future communication products. I'm especially excited to learn more about how to make health messages more inclusive and effective by applying the health equity lens. I'd also like to invite the audience to please submit your Q&A questions into the Q&A box, and we're just about to get started with Q&A. So thank you to all of our presenters. Now let's go ahead and move on to the Q&A section of our presentation. I apologize in advance if we're not able to get to all of the questions, but we will do our absolute best. The first question is for Dr. Banks. Can you please address economic inequality as a factor that results in health disparities?
Great question. Great question. I mentioned during my introduction that we are looking at the concept of gendered racism, okay, as part of our core goal, and that is the intersections how race and gender combine to actually cause an experience of racism that are different from either gender or sex alone. And one of the things that you'll know, I'll just use an example as far as employment. As you know, we've all heard, pieces of employment concerning the job reports. As we know, there are different types of COVID is exposed that, frontline workers are much more likely to acquire suffer morbidity and mortality due to COVID compared to other individuals who have, higher level jobs or, senior level positions. One of the great things that we're looking at now is a ratio of how that, taking that to the next level. I'm sure you're familiar with the data, Black men are about 5 to 6 times more likely to be incarcerated compared to white men, right? We can, you don't have to have a PhD in public health to understand it, how incarceration can have just deleterious impact on not just that individual's economic status, but also of their family, right? Both during incarceration and after incarceration. I'm just trying to make things very, very simple with our analysis. And we also look at, higher levels of senior level employment, right? Those, high paying jobs that allow individuals to lift themselves out of poverty and just provide the resources that link income, to health. What we're looking at, what we've discovered is that on average, Black men, in addition to being 5 times more likely to be incarcerated, you look at that ratio of incarceration to senior employment, you're about 30 times more likely to be incarcerated than to have those good paying jobs. All right, so there's just an example from there of how just economic circumstance can influence health. There are the number of health conditions that are associated with incarceration, and so you're higher risk of that, but you're also much less likely to experience the protective benefits of higher employment. So it's horrible analogy, but burning the candle from both ends, so to speak. And this is not new. It's being shared. I think that this year's county health rankings report, it quotes that jobs must lift individuals out of poverty as opposed to keep them in it. So it's a universally accepted phenomenon, and we are working around the clock to discover and uncover best practices to address it. Part of it is with our engagement with you here today.
Thank you, Dr. Banks, for your insights. It gives us a lot to think about, especially how underserved economic inequality, can determine whether or not you even have access to healthcare. So thank you very much for your insights. The next question is for Dr. Laird, and I hope you got enough of a break and a sip of tea, because I know you did speak for quite a while, but if you're ready, the next question is for you.
I'm ready.
Okay, let's go then. So it has been said that the word race is a construct. How do we remove it from our written and speaking experience?
That's a really great question. And does the word itself need to be removed, or does it need to be acknowledged and honored? I think by talking more about it, we will make a lot more progress as opposed to pretending that it doesn't exist, because it does. And we have an extensive history. I think we're doing some of the things here at CDC that I think other organizations would find successful. We're identifying health equity officers that will be within our divisions and even at program levels, not just at the very top of leadership, but throughout the programs, so that there will be people there to serve as educators, if you will, to be able to help us all understand where the challenges are and where we need to make the changes and the corrections. So I don't think the answer is to take it out of the construct. I think it's to acknowledge that it's there and then take action. I'm not sure that's the answer anyone's looking for there, but I think more importantly is to say, yes, this is here, this has happened, and here's some things that we can do. And then the commitment to making those things happen.
Oh, I appreciate that answer. Thank you so much. It makes a lot of sense. I have another question for you, Dr. Laird. Are you ready to move on to the next one?
Sure.
Okay, so how do we acknowledge culture, but also identify harmful culture that we do not need to cater to, like discrediting new ideas about gender identity or marriage or reproductive rights?
That's a very important question, especially in this current climate. I think
Absolutely.
Yeah, I think where we are is we have to stay in learning mode. Culture is changing. Culture is becoming more prevalent as a guiding force in how we behave and how we change our influence and how we make the kinds of changes we need to make in public health and in healthcare delivery. There's a lot more to culture than just language that people speak, but belief systems. I talk about, I give an example of my own father, when we talk about how we grew up, how did we learn from the people that raised us, and how does that make a difference in who we are today and how we interact with others? So in my own life, I did not grow up in a household where my parents were anti-Black. That was not part of the language in my household. But my father was a World War II veteran who fought in the Pacific Theater, and he absolutely despised Japanese. And there was nothing that I could say or do, or examples or writings, nothing was going to change his mind. And he went to his grave with the same attitude he had gained as an 18-year-old boy fighting in the Pacific. And I share that because when we're trying to teach and model better behaviors, the first thing we need to do is be welcoming to the difference of opinions and work hard to understand why they are what they are. If we have a more clear understanding of how people got where they are, we can do a better job of making the connections that we need to make so that we all can contribute to each other's learning process. You know, as I said, I talk about my own father because it's something that I experienced as a young kid. It didn't influence my own belief system, but it was present. And so I think when I think about other people who maybe grew up with other fears or other concerns, the first thing I want to do is understand where they came from, because I can't teach anything new about culture if I don't understand that to start with. I hope that's helpful. It's we have to learn first, and then we can understand, and then we can make the changes we need to make.
Absolutely. Thank you for your perspective. The next question is for Dr. Banks. Dr. Banks, are you ready?
Yes, ma'am. Yes, Racine. Absolutely.
Okay. So what are your thoughts or ideas about what we can do to help other demographic groups understand and care about disparity, especially since there are limited studies available, limited data available about these groups?
Just overall, I think being authentic, genuine, and inclusive, and to allow individuals time in the room and space to have candid, compassionate discussions. We live in a very, very divided and tense time right now. And part of the goal of this engagement today is to kind of provide a rationale of what we're doing, not try to be draconian or dictators, but to say, hey, this is all about respect and recognizing our differences so that we can reduce health disparities, and allowing individuals to ask questions and to not castigate or blame individuals for not always getting things right. We inherited this society, right? None of us here on this call today, owned any slaves. We didn't burn any crosses anyone, right? We didn't, lynch anyone. But these are the environments that we inherited, and so and we all come from these things from different backgrounds and different. We're affected by these atrocities of our past in different ways. The history of medicine is very, very ugly. It's a very, very ugly history, and we have definitely made steps to try to remedy that. But I think that allowing individuals opportunity to glow, these are difficult conversations to have. All right. When we talk about how the transatlantic slave trade, you look at the images of the ships, okay, the images of lynching, these things are triggering, all right, for a number of individuals. But to have an individual who may not, have that at the top of their mind every day. It's at the top of my mind every day. I wake up as a Black man. I can't escape. Right. But, allowing individuals who may not see that every day, where they may not have lived in urban environments or even had many opportunities to engage with Black men or individuals from any background, just having those open opportunities for candid, non-judgmental dialogue. One of the things that I find so discouraging about today is how individuals are scared to speak or to ask because you're constantly, blamed or castigated or just, ridiculed or reprimanded for just being, for lack of a word, just ignorant. I don't know. I can't expect you to know about my history and how these things, impact us, but when someone asks, particularly in a genuine, authentic way, give them room to, even though it may be clunky, at times are difficult to discuss, just appreciate the effort that, someone does. I can tell you how immensely I appreciate, Desmond, how has racism impacted you? right? How the things from George Floyd to Ahmaud Arbery, how those things, I love that because it just allows you care enough to care about how I feel. And just in as much as we can have as many opportunities to have that open, candid, non-judgmental dialogue from all representations of society, I think the better off we'll be.
I wholeheartedly agree. I think the turning point is being able to open and honestly have those conversations without judgment. So thank you. The next question is for Dr. Laird, and is in regards to the term that in your presentation that you marked as terms to avoid. One of those terms was marginalized. The question is whether you think that using the qualifier historically, as in historically marginalized communities, is that acceptable? When we take the focus away from the system and more on history.
That's a complex question for a couple of reasons.
Mm-hmm.
I want to repeat that, don't get hung up on the terms themselves, but understand the intent. Well, what we're trying to say is think person first language, a person who had this happen to them, a person who is at risk for, as opposed to categorizing everyone in one umbrella terminology. So I think the first thing we're going to have to do is start thinking in terms, and harder to do in public health than it is, healthcare tends to focus on the individual, where public health focuses on the aggregate or the community. And so when we think about terms of how we better communicate with the community and how we better serve the community, we have to start looking at where they are coming from and what needs to happen to change it. So that's not to say I ignore history. I don't. And I don't suggest we ever do that. But what do we need to get the community from where they have been to where they need to be and where they want to be? So, it's not about only the terminology, but rather what process can we change to make it better for them and subsequently for us? Because when all of our communities thrive, all of our other communities thrive. And that's the mindset that we have to start with. So it's tough to answer it just one straight question there, because I think it's the conglomerate of thought processes that we have to move forward with. We stop thinking about them in terms of where they've been, but let's talk about what we need to do to change where they've been. That means we have to acknowledge the history, but we also have to have the means, the mechanisms, and the desire to move that same population into where they need to be today.
Thank you so much. I think we only have time for one more question. This will be the last one, Dr. Laird, and it's in reference to a concept that was in your presentation. How do you recommend responding when a group or population is offended by updated, more inclusive language, whether it's outward facing, like on websites, reports, or during research and evaluation process? And the term that I'm referring to is the conversations that are happening right now about pregnancy and how we should term that, women with pregnancy or people who are pregnant.
Yeah, and I mention it myself because if I don't, somebody else always does, because it's been hotly contended since we started this work and continues to be. The first thing I want to say is not everybody's going to love you. When you're trying to do this work, you have to recognize up front that it's going to be hard. Not everybody's going to be happy. We can change some people's minds, and others we're not going to succeed. So we need to find the best ways that we can communicate with those people that don't want to hear some of the terms that we're constantly hearing this woke population. I'm honored if somebody calls me woke, but other people not so much. It's become a political tennis ball, ping pong ball. And we're not talking about politics. We're talking about taking the best care of all of us at the same time. And I think that's possible. I'm hopeful that we can make those things happen. We can start from a position of knowing that we've got a lot to learn. I'm still learning. And I hope everyone on this call is open to learning. So some of those constructs that you've had in your head from however you grew up and whatever generation and whatever educational exposures you've had, be open to a few more and then come to your own conclusions. And if you find that there are terms that suit you better or suit the community that you want to communicate with more effectively, then, let us know what they are. It's a work in progress. And as I said, I hope we can all continue to learn without just shutting down and saying, I'm never going to listen to that. There's no reason for me to change the way I've been. We all have our prejudices that we need to work with and to begin to understand. And so all we want to do is be inclusive and we want to be respectful of one another. And we're trying to encourage everyone to come from that same place.
Right. As you said, when you know better, do better.
That's right.
That's right. Okay, so we're just about out of time. We've gotten through a lot of questions, but if you did submit a question that we were not able to address, please feel free to email us at EPIC, EPIC, @cdc.gov, and we'll be sure to get the message out to the correct person and get an answer for you. I'd like to thank all of our presenters and our audience. If you wouldn't mind just doing a short exit poll on your way out, we'll go ahead and put that up for you now. Your responses can give a lot of information to the team on how to move forward and really inform some of the decisions that we make. So thank you again for taking the time to spend your afternoon with us and answer these questions. Okay, so our continuing education statements are up on the screen. Okay, so we are offering continuing education for this webinar. Please see the accreditation statements on the screen. To receive continuing education for the live webinar, please visit TCEO and follow the 9 simple steps. Before September 12, 2022, the course access code is EPIC, capital EPIC 0808. For others who are viewing the web on demand, in order to receive continuing education, please visit TCEO and follow the 9 simple steps before September 13th, 2004. Thank you all for attending. If you have any additional questions, please feel free to email us at epic@cdc.gov. And to learn more about CDC's emergency response communications, including past webinars and newsletters, visit our EPIC page at emergency@cdc.gov. You can find this recording of and others on the epic.cdc.gov's webpage and YouTube in the next 8 to 10 business days. Thank you very much for your time and all of the great questions. Have a wonderful day.